Okay, we ready?
Would you like to do the intro?
Okay.
Hi! Hi, Benchwarmers.
Hi, Benchwarmers.
What are we talking about today, Beck?
We're on episode, are we episode 5 now? Episode 5,
Yes.
We're talking about hypermobility, I think, today, and in particular EDS, which I can't say it, but you can say that syndrome.
Ehlers-Danlos Syndrome.
Yep.
So it's a hypermobility disorder.
Yep.
So thought we'd just have a little bit of a chat about it, and
In particular, like, just how to potentially treat people that are also quite flexible and hypermobile as well.
Yeah.
But also
relevance in sport as well,
Yeah,
I think would be really
relevance,
interesting.
Yeah.
So-
Because I recently have come across a few of these.
It's actually really common.
Yeah.
So I've working like clinic in Bundy. We worked with a rheumatologist out there,
Yeah.
a pediatric rheumatologist, and he used to see a lot of people who he would be diagnosed with EDS. We're going to call it EDS just because if we're saying Ehlers-Danlos
I can't
syndrome the
say it
entire
either,
time, it's
so-
a bit hectic.
Yeah.
So I've worked quite a lot with people with EDS, and even like at my clinic now, and I've got like family members who are diagnosed with it as well. So yeah, interesting.
Yeah, it's very interesting. Yeah, I definitely have come across it more often now, and I definitely, when someone comes in quite flexible and hypermobile, I definitely question that as well more often now as well. So
Yeah, because physios are normally like the people that actually end up pretty much diagnosing people.
Yeah.
So you tend to see it quite a bit in clinic, and because people with EDS and hypermobility will present to physio clinics with injuries because of the hypermobility.
Yes.
You tend to get a little bit suspicious, I think, of the people that are a bit more flexible than your average person, but also like the people who are having like recurrent shoulder dislocations,
Yes.
recurrent patella dislocations,
Yeah.
all those kind of things that you're like, it's just not normal for someone.
Yes. Yeah.
Yeah, so I guess starting off, so difference.
Yeah. What's the difference between hypermobility and EDS?
So EDS is a like diagnosable disorder, like a hypermobility. Oh, sorry, I shouldn't say that. It's a group of connective tissue disorders, and hypermobility is the most common type of EDS. Whereas hypermobility is just being increased mobility through your joints, and it normally doesn't reach the same set of like standards as like EDS, which is a actual connective tissue disorder.
Yep.
Which is a genetic disorder as well.
Yeah.
So that's kind of the big difference. So most people with EDS now are diagnosed clinically. So that means you'll go in, you'll see a physio, you'll see a doctor or a specialist. And based on your family history and your presentation and then a couple of different markers, you'll be pretty much diagnosed as EDS in that consult. You can have genetic testing, and they can look for genetic markers. Not all types of EDS, they know the genetic markers for all of them. So sometimes if you do go down that route, depending on the type of EDS that they're looking for, you won't be able to be diagnosed based on your genetics because they don't know the markers for it.
Oh, yeah.
But they don't generally kind of go down that route anyway.
Yeah.
They try not to. It's expensive, and like they don't have all the answers for it as well. So most of it's just clinically.
At the end of the day, is there anything medically that they can do for EDS?
That's a great question. I don't know medically. I know a lot of it's symptom management as far as I know from like the physio side of things as well it is. There's different types of EDS. So the most common is like your hypermobility, but there's also a vascular type. So there's 13 different types, but the most serious, most dangerous is a vascular type. Because it's a connective tissue disorder. So that means any connective tissue can be affected. So in your hypermobility, that's where you have like your collagen is the main one that's affected in that. So that affects like your skin elasticity, your joint elasticity. But you've also got, your VADS, I think it's called. So it's VEDS, vascular Ehlers-Danlos Syndrome, which is where like your heart tissue, blood vessels, those sorts of things, they don't have the same kind of structural integrity as they would in an average person. And so you're at higher risk of like stroke and blood vessels breaking and things like that, which is obviously really severe. The other interesting thing that comes with, like, I guess with EDS is like the comorbidity as well. So like you've got your POTS as well, which is something that you need to take into consideration as a physio. So that's like your postural orthostatic tachycardia syndrome. So that's, most people with EDS will also have POTS. And I think there is another condition that normally is a comorbidity for it. I can't really remember what one it is.
Because I thought someone was also telling me that your skin's also quite elastic.
Yeah, so it can be. So that's one of the markers that you'll often use in diagnosing your EDS. But you don't have to have elastic skin. So that's more of like, so you've got your hypermobility, you've got your classic, your VEDS, they're the more common ones. Your classic will be like your skin hypermobility, skin elasticity changes. So that's basically where like you'll lift up and you'll have like a really, really quick recoil. But also like just stretches kind of beyond what is normal. Not super common though, super common. So normally, like coming into physio clinic, what you'll normally do is, I guess like from your clinical history and things like that, you'll then kind of break down into a Baton score as well.
Baton score,
So do you want to kind of run through what your Baton score is?
Yeah, I don't really know if that really half the time really tells too much about hypermobility for this kind of thing.
I think anything above 4 is considered hypermobile.
Well, that's exactly right. But essentially, there's a few different testing on different parts of your limb, like your knees, if that knees hyperextend, if your elbows hyperextend. I think the other one is the weird thumb and pinky.
So I've got that one.
Thumb. Oh yeah, that way.
Yeah.
Thumb all the way to the forearm.
Yep.
And then the pinky, I think, past 90 degrees.
Yep.
Is also.
Yeah.
And that's on both limbs, so it's out of 9. Yeah.
And then lumbar extension.
Lumbar extension where you can touch the floor with your hands on the
flat,
floor.
with knees straight.
Yeah. And that's usually... But I had someone that I was querying with EDS, and I was looking at her shoulder range, and her shoulder range was like, it's 90-90. I swear she got to like 110 both ways. It was just like, other limbs were quite, like her wrist was quite flexy and stuff like that. So I don't know if it's necessarily, the Baton score is obviously a very outcome measure way of testing it, but I just noticed in other, like she had very high plantar flexion as well and things like that. So very interesting anyways.
The other interesting thing about like EDS as well is like there's often like facial features that are distinctive to like your EDS as well. So people with EDS tend to be a little bit shorter in stature. They tend to have like a pectus excavatum, so like basically like a almost like a divot in their chest. They'll often have like deep set eyes. Sometimes their ears, they'll have like more like protruding ears, like thin lips, things like that. So it's kind of interesting that like there is also like, because it's a disorder, there's a few characteristics like the physical traits, as well as like your joint hypermobility. Which is definitely like the most common. And so like I think as well, like as physios, you obviously were you taught much about it at uni, or has it kind of just been something that you picked up?
I think more about hypermobility and potentially how to treat it. Obviously, I think it was more along the lines of motor control and trying to, essentially you're not going to tighten up those joints at all, but you need to your muscles need to kind of take the load, but they are taking a lot of the load, and that's why they tend to get achy pain, because the muscles are so tight. And that's the thing, like you think, the muscles are tight, we might need to loosen you up, but no. And this girl in particular actually has been doing yoga, and I'm like, I don't know if yoga's more Pilates would be probably more better for you, but like Yeah, so stretching and whatnot, but no, we actually need to control your limbs in the space that they're in.
Yeah. So because there's like obviously that increased joint laxity, there's generally like a reduction in proprioception, so like your joint's ability to tell where it is in space relative to other limbs, which is why like especially in sport, people are like, you know, they'll tend to be the people that have like recurrent injuries, chronic ankle sprains, like chronic patella dislocations, shoulder dislocations, elbow dislocations as well, which it's hard to actually really hard to dislocate your elbow. It's kind of an interesting one. So,
and if you can imagine you doing a dislocation, it's painful. So
absolutely.
They're one of those ones that also can suffer from a bit of chronic pain. I've got another one that I'm also querying, but she gets a lot of it's potentially her pelvic floor. That's the issue.
I was going to say, so there's actually a lot of pelvic floor issues as well with EDS. So because you've got that increased laxity again through those ligaments, all of the ligaments through your pelvic floor, what tends to happen is you end up with increased muscle spasming and increased muscle tone through most of your pelvic floor to try and reduce the risk of basically like incontinence. And so people will end up with really significant like muscle spasming through like their entire pelvic girdle, and lots of issues basically related from that. So that's where you probably kind of refer down like the women's health, men's health kind of physio to help manage with that. But again, like actually really common, which is interesting.
Yeah. Well, she was coming in more for lower back pain, and it just so coincided her period would cause her extreme amounts of pain, and so I went more the pelvic health physio type side of things. But then I kind of went back and actually looked at her ranges again, and she could touch the floor, and I was like, let's check some other things and whatnot. I was like, okay, you're actually quite hypermobile, and I was just like,
which again, like I think that's an interesting consideration from like for women in particular, where they do have like those hormone changes, and like during ovulation, women, which again I think we should also do another episode on. Women, when they're ovulating, they have that increased laxity through that period, and so you're coupling that with a condition like EDS where you already have increased laxity in your ligaments, like it can be really quite painful. And then you're at a higher risk of injury, so like women are more likely to do their ACLs anyway. You couple that with ovulation, you couple that with a condition like EDS, it's like you're not really giving yourself much of a chance. But most women, like EDS is more common in women than men.
I was gonna say I don't think I've seen it in men yet. Actually, I don't think I've seen
had
one
a couple,
boy.
A couple, and that tends to be more, I guess, like the genetic kind of side of things. So you can obviously have it like inherited, but you can also have genetic mutations of it. But so it's more common in women, and the most common kind of age of onset of symptoms is sort of around that like 16, 17, slightly younger, I think, age. But it tends to be women who are, young girls who have gone through puberty. And it's also more noticeable around the time that they start giving up sport. So a lot of women who tend to be like dancers or gymnasts, which obviously like the hypermobility, the increased flexibility, it does have an advantage in that regard. But they basically have this reduction in physical activity, so they stop doing all of the strengthening exercises and strengthening that they were previously doing, and they normally get a bit of a flare-up of symptoms, which coincides with like the hormonal side of things as well, which as like physios you just you kind of have to be on the lookout for, screening for. Which is just kind of interesting. How do you go in terms of your treatment? Like, what do you kind of... Pilates.
More your obviously, like, your motor control stuff. Generally, the ones that I've seen recently are more lower back pains and things like that. But your bird dogs, I love a good Swiss ball as well. Getting you on the Swiss ball, doing some motor control stuff on a Swiss ball. If anyone... For some reason, people don't know what a Swiss ball is. But it's just the big... Yeah, every time I say, hey, do you have a Swiss ball? Do you know what a Swiss ball is?
I think it's a gym ball.
It's a gym ball. It's the big floor.
Same thing. Yeah.
Sitting on that, because that's, challenging your your core stability and whatnot as well.
Yeah.
But you know, that proprioception type stuff. So I love a good Swiss ball for this kind of population. But yeah, those kind of stability kind of exercises through movement. So
the other thing I think as well, which I then kind of also like to get like sports docs involved with, or even specialists, because a lot of the times the kids that you're seeing, and a lot of it is kids, they come to see physio because they've had a big injury, and so evidence in terms of like your management for these types of clients realistically is not participating in high impact sport. So there has to be a lot of education around swimming and cycling and things like that. And I think sometimes it's hard to be telling like a 16, 17-year-old kid, doing boxing, doing running, jumping, probably gymnastics, like probably isn't safe at this point, which I think is really hard, because the other thing, like it's a disorder. It's not something that you're just going to have for 6 months. It's something that is going to last a lifetime. Which I think can be hard as a physio. So if you can get a specialist or a sports doc involved pretty early, then I think that just kind of gives you almost a bit more of a team to just kind of provide a little bit more education. Which I think that's, I guess, from the physio side of things, and strengthening and endurance and pain management, I think are, more interesting. So yeah. But it's an interesting condition.
How do you tend to go about treating it, I guess? What are your go-to kind of exercises and things?
I guess like from like a general like fitness side of things, like I feel like I tend to kind of push like cycling, more like that low impact style of training or exercise, and then I try and I guess give a little bit in terms of like what people will enjoy, because it's hard to tell someone that they can't play footy or whatever. They can't do the sport that they've wanted to play or whatever. So I'll kind of try and generally go through a couple of different exercises with them. So I'll see if they're more interested in the gym stuff, see if they're more interested in the Pilates stuff. But then like that's, I guess, where like your POTS comes into it, where you do, as a physio, and anyone who's prescribing exercise for anyone with like an EDS or POTS, you have to consider the fact that this person can't get up and down and do lots of change of positionings, because they will pass out or like become really unwell. Their exercise tolerance can be quite low when they're changing positions all the time. So I'll generally try and do what they will enjoy doing, and try and base it around that, and then just do some general strengthening. I don't really give too much stretching or flexibility based stuff with any of these guys. No. They don't normally need it. No. They just need some good strengthening, and just try and specify it around whatever they're actually needing. Taping as well, like taping for joints as well, can help increase like proprioception around joints. Bracing.
Just tape the whole body.
Just tape the body like bubble wrap. Roll them down a hill. So I'll try and give people a little bit, but again, I think a lot of it comes down to education around like what, the fact that it is a disorder. It's not going to go away. It's something that they're going to have to manage, and the reason that they get pain is because they have this joint laxity. And just trying to normalize it a little bit for them as well. So,
are you quite flexible?
Some areas, yeah. So like my ankles and feet and toes and that, hypermobile, and my wrists and fingers and that are okay. My elbows are normal. They like don't beyond zero. My knees are a little bit hyperextensive.
You might be. No,
my back, my hammies are terrible.
I'm tight everywhere except for the shoulder. Well, just for hitting the volleyball constantly. It goes obviously so go back. But then my internal rotation's not as great anyway. But okay. That's interesting. I don't think I'm very
flexy. Well, yeah, but then that's the thing.
Arthritis is sitting.
She
Maybe
feels
we should
stiff.
talk about the other
But then I was
side of the
going to say, but
spectrum.
then that's also really interesting, again, with EDS, is that people who are undiagnosed EDS, sort of towards the end, like, you know, once they start getting a little bit older, they actually generally present as incredibly stiff.
Yeah.
So they kind of go the opposite way from all this increased joint laxity. They kind of start to stiffen as they get older, which is then kind of interesting, because then you can have like these 60, 70-year-old women who are professional ballet dancers coming in and they're like, I can't lift my hip because it hurts and it just doesn't move anymore.
I used to be really flexible.
I used to be really flexible, yeah. Yep, and they just kind of...
That's actually interesting.
Don't.
I wonder if I've seen a few clients that have just been like, I used to be so flexible.
Yep.
Oh, okay. Yeah.
Yep, and it's so interesting, like that.
So I feel
they
like
kind
it's
of
a fairly new-ish diagnosis.
It is.
Yeah.
It's almost like your ADHD and your ADD and like all that, like those kind of conditions. It's like, I think people are a lot more aware of it.
Yeah.
The other thing as well with like EDS, I guess, because there's a lot of symptoms that EDS has that all separately, they don't really, they can be totally explained by something else. But when people are presenting with, and this is where you do have to like put your medical hat on a little bit as a physio and kind of ask a little bit more around like different things. So like the other things that are really, really common in EDS is having like gastrointestinal issues. So because it's any connective tissue that's affected, they can have issues with digestion. So it's people that come in that are like, you know, have you had any issues with, do you get much stomach pain? Like, well, those kind of things. And it's normally like, yeah, I have all of these stomach pains, and do you have any bladder and bowel symptoms? And I think sometimes with physio you go, oh, red flags, bladder and bowel. But it's like, you can be like hypertonic. It's generally hypertonic, but you could also be hypotonic through like your pelvic floor. And so yes, I might have issues with incontinence. So it's not just, and then it's also like people with EDS, they'll often be like more frequently urinating and having to go to the bathroom. And so they don't have a good sense of if their bladder's full. But the gastrointestinal stuff, so lots of bloating, lots of stomach pain, lots of food intolerances. They'll often have heart palpitations, which kind of goes hand in hand with the POTS. So they'll have heart palpitations, chest pain. They'll have like the pectus excavatum. They'll have like blackouts, or they'll like lose consciousness, or they'll have like drop attacks and all of those kind of like cardio rest stuff, shortness of breath. And the other thing as well is, because it's a disorder, a lot of times people don't know it's abnormal to be having those kind of symptoms as well, which I think is really just, interesting. Like, I found out that I had hypermobility in my hands and my wrists 4 years ago. Before that, I didn't know, because I just thought it was normal. I thought everyone could bend their finger back 90 degrees. And so, like, having those discussions about, like, do you get lightheaded when you stand up? Oh, yeah, all the time, but no more than anyone else. Normal people don't get that.
I was going to say normal people don't get that,
So I think it's just kind of diving deeper into that real subjective stuff that gives you most of your answers. But when you kind of put everything together and you kind of go, okay, you've got digestive issues, you've got these bladder and bowel signs, you get lightheaded, you've had drop attacks, you have these weird cardiac things. And just because you have POTS doesn't mean you have like the vascular type of EDS. But then it's like, okay, but then you also have this joint hypermobility. Okay, we're putting everything together. You probably have a family history. You probably have, if you've got a sister, they probably were a dancer. They probably were quite good at dance, or, just kind of putting those things together. And then that's when you kind of go, okay, you probably have EDS. You can go down the route of genetic testing if you want. Probably won't tell you yes definitively, but we can say clinically you have it. Which is interesting.
Very interesting.
Anyway.
Yes,
But I think as well, like, doctors are often not aware of it.
I was going to say, this client came to me pretty much, she'd told me that she thinks she has it, and her doctor pretty much said, no, I don't think you have it. Go see the physio and she can sort it out. And I'm like, I was like,
that's it.
Yeah, you probably.
But doctors are like, I think they just don't know about it. Like, I've had so many clients.
Well, the doctor said to her that it's not that common. And I was just like, I feel like it's...
It's so common. It is common.
Yes, yeah. So, no, that's very interesting. But yes.
Yeah, wow. Yeah. That's so funny, isn't it?
Yes, yeah.
But I think, like, it was...
But people, it's the same thing. If you don't know about it, you don't know about it. But, I only know about it because it's been coming into my clinic so often. That's because it is quite common.
It's actually quite common.
Yeah. So, it's definitely, I think, up and coming kind of, like you said, ADHD and AD, things that are just becoming more aware of now. So, yeah. No, it's very interesting.
It is interesting. Yeah. So,
but I don't want to get stuck in the path of just being, you're hypermobile. You might have EDS.
Yes. Yeah,
so,
exactly. Yeah.
So it's probably good to know for other physios and myself included.
No, but it is. I think as well. Like just and if someone has hypermobility, like you're gonna treat say they score like a 2 out of 9 or whatever on the bank, and you're gonna go, you got hypermobile ankles or you got hypermobile knees or whatever, and you're like, okay, cool, so we're just going to treat that proactively. Do your normal injury prevention stuff and just accept the fact that there's probably a bit of hypermobility there, but you don't have a diagnosable disorder. No. And therefore you don't really have the same kind of risks that come along with that. Yeah.
At the end of the day, as a physio, obviously we need to be mindful of the POTS and the those kind of things, but also we're realistically just treating the motor control and making sure that they can.
That's exactly right. Yeah.
Management of it essentially.
That's exactly right. So and education and I think helping with the pain side of things as well is interesting. But there's actually a couple of clinics that I know about that are just EDS clinics as well.
Oh, really?
Yeah.
Do you, because I've actually been wondering this, and I've had a client come in last year, but it's not on NDIS, is it? It's not disability.
Oh, that's a good question.
She was trying to advocate for it. Fortunately, this other client also has autism, so she's autistic and has...
Yeah, so because neurodivergence is one of the comorbidities as well with EDS.
Yeah. Actually, there's been a couple with autism that have it.
Yeah, so it could, I think a lot of times as well, like you go by... I have a feeling EDS is on NDIS, but I think it's really, really low funding.
Yeah, I think it's quite difficult.
I think most of the time...
I think she gets more funding for autism.
I was going to say, I think you'd be better off getting like autism or something like that, because I'm pretty sure the funding for EDS is like crap. It's the same with functional neurological disorder as well. That's like, people can get diagnosed with FND, but like if you have another condition, you're generally pretty well better off to like if you've had a stroke and then an FND or something like that, you might as well just make your stroke your primary because FND doesn't really have any funding. Which is interesting. But that's a whole nother topic.
Oh my god.
Whole nother topic. So
NDIS in itself should be old.
NDIS.
Although we're predominantly sport physio, but
we both have worked in. Do you have NDIS clients now?
I do. I only have. They limit us to like 5 or 6 a week, which is nice. I still like neuro still. But seeing my disability clients, but all day, every day, not so much. Because it's rewarding, but it's a very delayed, long reward. And sometimes...
The hard thing with NDIS, though, is like they don't really want people to get better.
No, as well,
do you know what I mean? Like, it's like you don't really... Like, as a physio, you do. But it's like NDIS, for them to be on NDIS, it's like they shouldn't really be getting better. Because it's an insurance scheme.
Maintaining their
maintaining the where they are
and stuff as well.
So then it's like, anyway.
So
NDIS is.
I got very good at wording my reports to say they're just this is more about maintenance, so that they don't need extra care later in life. That'll keep them independent. Quality of life will, which it is. You're definitely doing that in regards to keeping them functionally going, but yes, it is And that's why I think it was a bit draining's probably a bit of a harsh word, but you know,
there's a lot of work that goes into it though. Like there is, because there's so much paperwork.
Yeah.
So much paperwork. So you're not just doing like your normal, you know, and you invest in those clients as well. Yeah. That's the thing. You invest in all of your clients and.
And it also, I mean, it's anything with anything third party. They're not people who are deciding the funding, like work cover as well.
No idea have no idea.
No health background whatsoever. And they're saying, well, shouldn't they be better, or shouldn't, like, why is this not, like, what are you doing? What are you doing? Like,
they should be better. They have had their 5 sessions. They should be better.
They don't need any more funding. Well, I'm telling you they do. Yeah. So, and I've done the degree to tell you that they do. They do. So, I probably struggle with that as well. And it's also, in the past, I've just had people who I think definitely need NDIS struggle with getting funding, and then people
who don't really seem to need it.
Really need it.
Yep, get a lot.
We're probably diving into this a bit too much, but autism in itself is obviously something as physios we can do in the early stage of life. Particularly with gross motor skills and things like that. But I found there were kids that I thought were actually pretty functional, and they were still getting quite high levels of funding, and I was just like I understand why they need it, but at the same time I feel like I don't know.
The thing that I find funny is and dealing with those kids, not so much as the kids, I find more the parents, but I find it really funny that I've had a lot of parents get like quite protective over the money, and I'm like, it's not your money. Yeah, it's literally not your money. It's government money. Yeah. Why are you being so stingy with it?
It's also you always see one parent, you're like, that's where you got it from.
Yeah, that's exactly right.
You're autistic. That's your autistic parent.
That's your autistic
because it's genetic, isn't it? It's genetic.
Yeah, there is a genetic link. Yeah.
So it's always quite funny and be like, But yes, you do get those parents.
I had a gorgeous little boy who I was seeing for autism, and the couple of episodes. Couple of sessions. I was like, I'd see his mum out in the waiting room, would have a chat for a bit, and I genuinely was like, okay, she has autism, and that is where he got it from. Yeah. And then one day, his dad brought him in for the session. And no, the dad has autism.
The dad has autism.
I literally was like, oh, no. Yeah. The mum is odd and probably does have autism. But the dad was just like, he like wouldn't give me anything. And I was like, he did really well. He's like, okay.
Yeah. You know what? My favourite show of all time, though, is Love on the Spectrum.
I love Love on the Spectrum.
Absolutely.
Georgie and Connor. Oh my God. I literally was on the Instagram last night.
Yes.
They're cute.
I love
Abby.
Michael on the Australian version.
Yeah, he was cool.
He's a vibe.
Have you seen Abby's song? Abby and...
Yes.
You can get that on Spotify.
You can. She did so well, actually.
She did so well.
Vibing. I actually didn't. Show. I wasn't a fan of. Is it David at the start? But David. Then I grew to love him. I grew to love him, and they are very much a match made in heaven, obviously as well. Yeah. Anyways, that's probably a bit off topic, but
like kind of cute.
Yeah, very cute. Yeah. On the
spectrum.
Do you have a? Do you have autism?
Do I have autism?
Yeah, I talked to this about my teammates when we were out in the tournament last week. Yeah, what's your autism? So like one of them was like, you have to have a specific spoon. So you can't have the soup spoons or anything like that. You'd struggle with.
I am very weird with my cutlery. Yeah. I definitely have. Well, I mean, I have ADHD.
Oh,
I think that's.
Oh, I definitely have it as well. I mean, where's that?
I was like, I think we know this. And then I'm like, I don't have autism, but then I have to have like cutlery. Yeah, I've got various it's not just like the right shape, it's the right weight. It has to weigh a certain way.
Really?
And that's what I mean. Yeah. I'm definitely on the spectrum.
Yeah.
But
I feel like everyone is.
Most women are.
It's a spectrum.
And they must.
Oh, yes.
Yeah. Another topic. But it's got to be like. So I'm giving out all the secrets here, but it's like if I put it on my finger, it's like got to weigh a certain to the head versus the tail of the spoon. Yeah. I don't know. It's just a thing. And then like that's texturally, I have like a big texture things where I'm like, I can't eat food if it doesn't have a certain texture to it. I've never eaten, I have now, but up until last year, I'd never eaten a banana because, like, the idea of it in my mouth is like...
I'm the same, actually. I can do banana flavour. I can't do banana itself.
Yeah.
Yeah, the texture is a bit weird.
It's too bad. Yeah. I have to wear socks.
You have to wear socks?
I hate wearing no shoes inside and socks inside. So I have to wear, like, socks on carpet. And if I'm going down to, like... If I'm going outside or if I'm going, like, I'll generally 99% of the time wear shoes in the house because I just don't like things not touching.
Very sensory of you, yeah.
Very sensory of me.
Yeah.
I think that's most of my tisms.
Oh, fair enough.
No, there's definitely about 1 million more, but that's all I'm willing to tell.
Maybe people can...
Can you guys tell us your tisms?
Yeah, please tell us your tisms.
Tell us your tisms. What's your tism?
Just the funny, interesting things that you do. Well, I jiggle my leg, but I don't know if that's a tism. That's probably more of an ADHD thing.
That's an ADHD thing. But that's they go hand in hand.
Yeah, people thought it was anxiety. I just do it all the time.
Yeah.
I just can't sit still like half the time. Like I really just jiggle my leg all the time. And so much so, my mum, like when we're driving, my mum will be stopped at a red light and I'm like, Becca, stop jiggling the car because I'll set the thing off or whatever it is and the whole car will be shaking.
I can't relax watching TV if I'm not on my phone as well. I need to have like multiple areas of like input where I'm like on my phone watching. Yeah. My dad used to get driven crazy because he'd be like, we're watching a TV show. I'm like, I'm watching. Like I can tell you exactly what's just happened because I've been like scrolling and just like,
Oh, 100%. It's another social media. TikTok, love me some TikTok. I struggle with cleaning up sometimes and whatnot. And apparently you should just put it away straight away. Don't put it down somewhere because then you're just going to...
I forget a lot.
Yeah. So you need to think about just put it away straight away. Don't have the extra step of putting it down somewhere. And putting it somewhere else. Yeah. So it's a good little tidbit. But anything.
Tell us your tisms. Tell us your funny tisms.
I was trying to think if any of my friends had some other ones. I think it was all the spoons and forks. I don't like the 3-fork one. I hate the free fork. I
didn't even know there was a 3-fork.
Yeah, there was ones with free. I like long forks too.
It just has to weigh and look the right. Like they've got to be like the right length fork.
Yeah.
And then like head of the fork.
Yeah.
To the body.
Yeah.
And like it's just got to be right.
I don't like if I have a wine glass. I like a big cup wine glass. I can't do little ones. I can't do little.
Yeah.
I don't know.
And you go with like textures of things. Like I hate velvet. Velvet.
Yeah,
Silk.
Actually, that's no, suede as well. I'm not really a huge fan of either.
No.
Those kind of textures and things.
They kind of gross me out.
Yeah. I actually don't like your dress shirts sometimes, like the really
like nylon-y, like
not cardboardy,
like your blouse sort of.
Yeah. And I'm just like boxy, and I don't like them.
Not
I just
a fan
like
of
that.
It's got to feel good,
flowy kind of things.
Yeah.
But yes, Anyways, I think
we've kind of gone off topic.
We have. What were we talking about?
That's very ADHD of us.
Very ADHD of us. But
hypermobility is different to EDS.
I'd be very interested to hear if anyone has any hypermobility or any stories that they've come across or whatever, but more so their tisms. I really want to know people's tisms.
Yeah, tell us your tisms. Tell us your tisms. We should have a new segment.
Yeah, maybe we should have a new segment about, I don't know, your tisms?
The tisms. It's so funny though. Some people's like, I don't know. You know how like you dissociate? You do that where you're like, you'll just like fully not be present? Yeah. That's funny.
Oh, like you'll be talking to someone and then just completely zone out.
No
I think
idea.
that's an ADHD thing though.
But same.
Yeah. One of my
work.
My pro volleyball.
Let's just drop that in there. My pro
volleyball friends. She was very. I don't know if it's tismy, but very clean, freaky. Has to constantly wash her hands, kind of thing.
Yeah, OCD.
OCD doesn't like. I feel like people don't like their feet touched as well.
It's like,
it's just like don't touch your feet, type thing.
Yeah.
So she really icky, really like stuff like that. So that's quite funny.
Do you know what's so funny though is like as I've gotten older, like I've realized that most of my friends that I am like good friends with are ADHD.
Yeah.
And I'm like, we just vibe.
Yeah.
We just get it.
Yeah, exactly.
I love it.
I get in trouble a little bit for hyperfixating.
Oh, I hyperfixate so much.
If I am on my phone and you're talking to me, I won't hear you.
Yeah, no. I had the same issue when I went to Japan. Chris and Emma. Shout out to Chris and Emma. Love you guys. Literally they would have conversations with me and then I would hear them laughing.
Yeah.
And then I'd like look up from my phone and they'd be like, we just said something like really 3 times. And I'm like, no, you didn't. Yeah, we did.
Yeah,
and it happened constantly.
Yeah, okay.
And I was like, it's not. But it was happening a lot.
Yeah.
Every 5 minutes.
Yeah, it's bad. But ADHD people, I feel like, are quite intelligent as well.
Yeah. So ADHD people are people with ADHD tend to be, particularly women, tend to be high performers.
Well, there you go.
There you go.
There you go.
There you go.
Yeah.
Take them on for the team.
And we don't even take anything. Do you take anything? No. That's exactly.
No, I like the way my brain works. It flicks from subject to subject.
I actually
really
started
funny.
taking Vumi supplements. Have you heard of these?
What?
We don't have a sponsorship, but let's maybe talk about it. It's like a supplement for your brain fog and all that kind of thing. Yeah, she created it because she has ADHD and has busy brain, so busy brain people. So I've started taking that in the day, and I find well, I always by 2-3 o'clock I kind of like really struggle. But I found I've only been taking it for like a week, I think, and it's actually been really
that's pretty
good.
Cool.
Yeah. Also, because I've been trying to tell people to take creatine, I put a bit of creatine in there as well for muscle recovery because I'm getting sore. That actually happened after I played my first indoor tournament in like a year since I've retired
from her pro volleyball.
I was playing beach before, which is a lot easier on your joints. But I played my first indoor tournament for a weekend. This past weekend, I was sore for 3 days. 3 days, and I'm like, I'm starting. I'm getting on the creatine vibe. So that's what I did. But,
so now you just have to tell us if it works.
Actually, well, yeah. Well, creatine takes a bit, doesn't it?
I think so.
Yeah. So
I don't know too much about
it. We'll see. I'm also very bad at doing things regularly, though.
ADHD, same. I have a box of, like, a thing of creatine down there.
Yeah. Like, just before work I can do, but on the weekend I probably goes out the door. Yeah. But anyways.
Luckily, creatine isn't something you have to be super consistent with.
Mm-hmm. Yeah.
That's a lie.
Yeah.
All right.
Anyways, guys, that was a good episode, I think. Yeah. All right. We're not going to do it from the bench because
nobody's fucking submitting shit.
No one's submitting anything, but this will be 3 weeks from when we
when we post it.
When we actually post this. Next time we hopefully have heaps and heaps of from the benches.
Yeah, we'll just keep bothering everyone.
Just keep bothering people
and just telling them that they have to. And
but we'll maybe make tell us your TISM or your from the bench. Those two.
Yeah, we want both of them.
Yeah. All right. Thanks, guys.
Bye.
Bye.